Welcome. In this session, we are going to discuss the congenital abnormalities of the eyelid. However, we will defer discussion on congenital ptosis, ectropion, and entropion in the respective sessions on ptosis, ectropion, and entropion, and also defer our discussion on congenital benign eyelid lesions such as capillary hemangioma, port wine stain, and nevi to the session on benign eyelid lesions. In Telecanthus or Dystopia canthorum, there is a lateral displacement of both inner canthi. As we see here in this picture, the medial canthi are located further away from each other than they normally are, and there is a Farkas canthal index which tells us that the normal ratio of the distance between the two inner canthi and the distance between the two outer canthi lies between 38 and 42. In Telecanthus, the line joining the upper and the lower puncti of each eye passes through the cornea, and Telecanthus is a characteristic feature of Waardenburg syndrome. So this is actually a patient with Waardenburg syndrome. Blepharophimosis syndrome, also called Blepharophimosis ptosis epicanthus inversus syndrome or BPES, is usually an autosomal dominant condition with mutation in FOXL2 gene in chromosome 3, but can also be sporadic, and it is a bilateral condition. The characteristic findings of BPES are blepharophimosis with horizontal and vertical shortening of the palpebral fissures. We also find severe ptosis with poor levator function and absence of skin crease. Epicanthus inversus, which is a fold of skin running from the lower lid over the medial canthus. And also Telecanthus, that is increased separation between the two medial canthi. Other findings of BPES are depressed bridge of nose, hypertelorism, lateral ectropion of the lower eyelid, high arched eyebrows, hypoplasia of the superior orbital rim, and low set ears. And there are two types of BPES, with type 1 being associated with premature ovarian failure, and type 2 is an isolated disorder in which only the eyes are involved. Correction of blepharophimosis requires multiple staged surgeries for the various component anomalies of BPES and is usually done at the age of 3 to 5 years. A YVplasty or Z-plasty is required for the telecanthus with or without tightening of the medial canthal tendon. Telecanthus repair is usually done first, as telecanthus repair may cause worsening of the ptosis. And in YVplasty, a Y incision is made with the two arms of the Y placed along the skin fold of the epicanthus inversus. Then gentle subcutaneous dissection is made along the incision, and following that the junction of the two arms of the Y is attached to the base of the stem of the Y, which results in the medial canthus being pulled towards the bridge of the nose and wider exposure of the nasal sclera. Ptosis repair requires frontally sling because of poor levator function and is usually done following telecanthus repair, but it may need to be done early if severe ptosis causes visual obstruction. Repair of the epicanthus, if required, is usually done at the very end. In Euryblepharon, there is a vertical shortening and horizontal lengthening of the lower eyelid, and the horizontal lengthening is mostly in the lateral aspect of the lower eyelid with widening of the lateral palpebral aperture. Patients with Euryblepharon may have a downward slant of the lateral canthus, and Euryblepharon is associated with blepharophimosis and Kabuki syndrome. Exposure keratitis can occur due to impaired blinking, and treatment of Euryblepharon includes tightening of the lateral canthal tendon, attachment of the suborbicularis fat to the lower orbital rim, and horizontal shortening of the lower eyelid. Ankyloblepharon is partial or complete fusion of the upper and lower eyelid margins. When partial, it is called filiform ankyloblepharon as seen in this picture, and filiform ankyloblepharon can be part of Havel syndrome. And ankyloblepharon can be easily released by clamping for hemostasis followed by sectioning with scissors. Epicanthus is a vertical crescent-shaped fold of skin lying over the medial canthus, and four types of epicanthus are known. Epicanthus tarsalis, in which the skin fold is most prominent in the upper eyelid, Epicanthus inversus, in which the skin fold is most prominent in lower eyelid, as we find in Blepharophimosis syndrome, Epicanthus palpebralis, in which the skin fold is equally prominent in upper and lower eyelids, and Epicanthus supraciliaris, in which the skin fold extends from the eyebrow region to the lacrimal sac. Epicanthus is usually a bilateral condition resulting in decreased exposure of the nasal sclera, resulting in the appearance of a pseudo-esotropia. Most forms of Epicanthus except Epicanthus inversus resolve on their own with maturity of the facial bones, and treatment is considered only after maturity of the facial bones, and Z-plasty and YV-plasty is required to correct the skin fold. In Epiblepharon, skin and pretarsal orbicularis rides over the lower eyelid margin to create an extra fold of tissue over the medial aspect of the lower eyelid. So this is the extra fold of tissue which obstructs visibility of the eyelid margin of the medial aspect of the lower eyelid, but the eyelid margin of the lateral aspect of the lower eyelid is visible. Epiblepharon occurs due to deficient attachment of the lower eyelid retractors to the skin, and the cilia on the medial aspect of the lower eyelid are oriented vertical, but corneal touch occurs infrequently and only in down gaze. Epiblepharon usually disappears with maturation of the facial bones, unlike congenital entropion, and treatment is indicated if there is corneal staining and is done by removal of the extra fold of tissue with outward rotation of the lower eyelid margin. Congenital distichiasis is a rare condition and is often hereditary, where there is an extra row of eyelashes in place of meibomian gland orifices. So we find extra row of eyelashes along the upper as well as the lower eyelid in addition to the normal eyelashes, and it is said to occur due to the improper differentiation of the pilosebaceous units to hair follicles. These pilosebaceous units are normally destined to become the meibomian glands, and the abnormal eyelashes as compared to the normal cilia are shorter, thinner, less pigmented and softer, and usually do not cause keratopathy. Treatment of distichiasis is indicated only if the patient is symptomatic or keratopathy develops, and treatment can be initiated with lubricants and contact lenses, but ultimately removal of the abnormal lashes may be required, and usually it is done by electrolysis, radiofrequency ablation, or removal of the abnormal hair follicles after splitting of the eyelid margin at the gray line. Cryotherapy should not be done at the eyelid margin because it causes loss of the normal eyelashes as well as thinning, notching and hypopigmentation of the skin of the eyelid margin. Congenital colobomas are embryonic clefts in the eyelid, and true colobomas involve the eyelid margins as seen here in this picture. Colobomas in the medial upper eyelid can be an isolated finding, but it can also occur in golden heart syndrome. However, colobomas in lateral lower eyelid are usually associated with other defects such as Treacher-Collins syndrome and golden heart syndrome. Colobomas of the eyelid can also occur from amniotic bands, and the colobomatous eyelid can be attached to the eye. Colobomas of the eyelid are usually not associated with colobomas of the iris or the choroid. Eyelid colobomas require treatment to prevent exposure keratopathy, and smaller colobomas involving less than 1/3 of the horizontal length of the eyelid margin can be opposed by creating sliding flaps with the help of incisions along the eyelid crease. Larger colobomas need repair with the help of semicircular flaps created near the lateral canthus, and eyelid shearing procedures, which are two-staged procedures, should be avoided in young children because of the risk of amblyopia developing between the two stages when the upper eyelid is fused to the lower eyelid. In Cryptophthalmos, we find a continuous layer of skin from the forehead to the cheek, and Cryptophthalmos can be partial or complete with absence of eyebrows, eyelids, eyelashes, palpebral aperture and the conjunctiva. Cryptophthalmos can be an unilateral or bilateral condition, so we find a continuous layer of skin extending from the forehead to the cheek. Adnexal tissues such as the skin overlying the globe are atrophic and malformed and are fused to the anterior segment of the underlying eye. The underlying eye is typically malformed, usually having microphthalmos with or without an orbital cyst. Cryptophthalmos is associated with Fraser syndrome, with syndactyly and genitourinary anomalies, and treatment of cryptophthalmos is usually not successful because of the anomaly of the underlying globe. In Epiblepharon, the eyelids are absent or severely hypoplastic, and this is a very rare condition resulting in exposure keratopathy. Epiblepharon can occur with macrostomia as seen in this picture. In congenital tarsal kink, there is an inward folding of the tarsus towards the globe, resulting in entropion and trichiasis, and this leads to corneal ulceration. Mild cases can be managed by taping the eyelid shut for 2 to 3 days following birth, but severe cases require incision of the tarsal plate with placement of everting sutures as shown here in this picture. Normally, the lateral canthus is located 1 mm higher than the medial canthus, and upward palpebral slant in which the lateral canthus appear higher than normal occurs in Down syndrome. Downward palpebral slant in which the lateral canthus appear lower than normal occur in Treacher-Collins syndrome. So we see a picture of Down syndrome here and of Treacher-Collins syndrome here. Because of the palpebral slant, A or V pattern strabismus can occur. Marcus-Gunn jaw winking phenomena is a synkinetic congenital cranial decenervation disorder in which we find elevation of the upper eyelid with movement of the jaw, such as clenching and sideways movement of the jaw. And it occurs due to an abnormal connection between the motor division of the trigeminal nerve, which supply the pterygoid muscles moving the jaw, and the superior division of the ocular motor nerve supplying the levator palpebrae superioris, which elevates the upper eyelid. Marcus-Gunn phenomena can be unilateral or bilateral, and it is usually associated with ptosis. Thank you for listening.